Second white coat. Subscribe and like. Let's learn medicine together.
Welcome to The Explainer. Today, we're literally getting inside the mind of a top-tier test taker. We're going to deconstruct a really complex board-style medical case step by step. So if you've ever stared at a massive question stem and just felt instantly overwhelmed, yeah, this is for you. We're putting on our clinical detective hats to break down the differential diagnosis and, most importantly, separate the actual signal from all that clinical noise. Here's a quick look at our roadmap. We'll start with the clinical vignette, decode the key exam clues, review amyloidosis basics and types, dive into the pathophysiology of the answer, and finally, look at some exam shortcuts and traps.
All right, Section 1, the clinical vignette. Let's get right into the case.
Okay, here's our raw data. We've got an 81-year-old woman with type 2 diabetes and end-stage renal disease, or ESRD. She's been on hemodialysis for a solid 10 years. Now, she presents with bilateral shoulder hypertrophy, a burning pain in her thumb, index, and middle fingers, some thenar atrophy, and soft tissue fullness at the right wrist. And the question wants to know which tissue deposition is most likely responsible for her condition. At first glance, right, this is a super complex patient presentation packed with multiple distractors. Your job as the clinical detective is to extract that diagnostic signal from all the noise.
Section 2, decoding key exam clues. Translating this raw data into clinical meaning is going to immediately narrow down our suspects. Let's isolate those trigger phrases. 81-year-old isn't just a random demographic. It tells us her risk for amyloidosis naturally goes up with age. ESRD reveals her kidneys are failing to clear certain proteins from her blood. And hemodialysis for 10 years? That is a massive, incredibly high-yield trigger phrase. Long-term dialysis leads directly to the buildup of a specific protein called Beta2-Microglobulin. Then we look at the physical symptoms. Bilateral shoulder pain and hypertrophy. That translates to abnormal deposits physically thickening the tissues around her rotator cuff. And the burning fingers and thenar atrophy? That's a textbook description of median nerve compression, basically carpal tunnel syndrome, which is backed up by the wrist fullness indicating actual physical deposition right inside the carpal tunnel. You see how these puzzle pieces just snap together to form a highly specific clinical picture?
Section 3, amyloidosis basics and types. Let's do a quick refresher.
So the crucial thing to remember here is that amyloidosis isn't just one single disease. It's a broad category defined by proteins taking on a toxic, misfolded shape that our bodies just can't easily get rid of. It's basically a stepwise failure. A protein is either overproduced or not cleared out properly, and then it misfolds into a beta-pleated sheet structure. Think of it kind of like biological concrete. Because of this really rigid, abnormal shape, our body's normal enzymes simply can't break it down. So it deposits outside the cells, in the extracellular space, where it literally crushes and damages the surrounding organs and tissues. Now, the naming convention you'll see on test day is thankfully pretty straightforward. Amyloid always starts with an A, attached directly to the abbreviation of the specific precursor protein that misfolded. So if an immunoglobulin light chain misfolds, it's AL, serum amyloid A, AA, transthyretin, ATTR, and beta-2 microglobulin becomes A beta-2M. Memorizing this prefix system is an absolute must-know board shortcut. Seriously, half the battle of branching your differential is already won just by recognizing these letters.
When we branch out this differential diagnosis, you really want to note the stark differences in classic manifestations for each precursor protein. AL, or primary amyloidosis, stems from a plasma cell dyscrasia. Think multiple myeloma, nephrotic syndrome, and macroglossia. AA, the secondary form, comes from chronic inflammation or severe infections and hits the kidney, liver, and spleen. Then we have ATTR, which comes in two main flavors: the mutated hereditary form causing neuropathy and cardiomyopathy in younger patients, and the wild-type, age-related form causing similar cardiac issues plus carpal tunnel in the elderly. And finally, A beta-2M, our dialysis-related amyloidosis. Notice how perfectly this matches our patient, ESRD on long-term dialysis leading to shoulder pain, bone cysts, and carpal tunnel syndrome. It is a perfect match.
Moving on to Section 4, pathophysiology of the answer.
Let's trace the flawless, logical chain of events here. It's a simple, highly testable mechanism. Step 1. Beta-2 microglobulin, which by the way is a completely normal structural part of MHC class I molecules found on all nucleated cells, is continuously shed into the blood. Normally, healthy kidneys clear it, no problem. But step 2, in a patient with end-stage renal disease, the failing kidney just can't clear it.
Step 3 is the paradox and really the high-yield turning point of this entire case. While hemodialysis is an amazing replacement kidney for filtering out a lot of toxins, it completely fails to effectively remove this specific protein. So step 4, over 10 long years of dialysis, the beta-2-microglobulin relentlessly accumulates and physically deposits right into the joints, tendons, and wrists.
And this simple accumulation mechanism beautifully explains our 81-year-old patient's exact presentation. That massive protein deposition in the rotator cuff, that gives us the bilateral shoulder hypertrophy, and the deposition in the wrist structurally compresses the median nerve, giving us her burning finger pain and thenar atrophy, classic carpal tunnel syndrome. So without a doubt, the correct answer to our clinical vignette is tissue deposition of beta-2-microglobulin.
Finally, Section 5, Exam Shortcuts and Traps. Let's talk about what the test writers are trying to do to you.
We need to practice active elimination. Let's look at the primary traps they set up. Choice A, free immunoglobulin light chains, describes AL amyloidosis. This is strictly tied to plasma cell disorders, like multiple myeloma. If the vignette wanted you to pick AL, they would almost certainly explicitly mention macroglossia, an enlarged tongue, or purpura. Choice B, amyloid A protein, is secondary to chronic inflammatory states like severe rheumatoid arthritis or tuberculosis. Notice how their distinct patient populations, plasma cell disorders versus chronic inflammatory states, just absolutely do not match our long-term dialysis patient.
Okay, now let's look at transthyretin. Choice D, the mutated form, is hereditary, and you're typically going to see that in much younger patients. Choice E, the wild-type form, man, this is the real high-level trap here. It's age-related. It's often seen in the elderly, and guess what? It can even cause carpal tunnel syndrome. But while wild-type ATTR does cause carpal tunnel in older folks, it generally presents with restrictive cardiomyopathy. Crucially, it doesn't cause that classic shoulder disease you see after a decade of hemodialysis. Because our patient has that very specific shoulder hypertrophy combined with a massive 10-year dialysis history, we can confidently cross wild-type ATTR off the list.
I really want you to lock this memory device into your brain right now. When you see the word dialysis in a question stem, I want you to immediately, reflexively think dialysis equals B2 builds up, B2M goes straight to the structural areas, the bones, the joints, the wrist, and the shoulder. It's a direct, incredibly high-yield association that's going to save you vital time on test day.
So here is your ultimate takeaway formula. Long-term dialysis plus shoulder pain plus carpal tunnel equals beta-2-microglobulin amyloidosis. If you can make these associative pairs completely reflexive, you are going to easily bypass all those traps on the exam. Which leaves us with one final question to ponder. The next time a truly complex, multi-system patient walks into your exam room or pops up on your screen, are you going to get distracted by all the noise, or will you know exactly which trigger phrases break the case wide open?